Good morning, everyone, and welcome. It's such a pleasure to virtually welcome you here at the House of Sweden in Georgetown. Of course, I would have wished you were here live. I'm sure we will be, but right now we have to settle for virtual. We're right by the Potomac River here in the wonderful Washington, D.C., and we are nearing one of the most beautiful times of the year, the cherry blossom season. Well, so thank you all for tuning in to today's seminar on the topic of life science. I think in our lifetime, there has never been such an interest in life science and healthcare. We have all followed the news closely on how vaccines and medicine are developed and tested, and how healthcare systems and healthcare workers have been stressed, and the need for international collaboration and innovations. We are learning new things every day. The title for today's seminar is Transforming Healthcare to Opportunities. Besides all the challenges, the pandemic has provided us with a unique opportunity to redefine healthcare. So in the seminar today, we will focus on 3 life science and healthcare topics, how they have been impacted by the pandemic and opportunities ahead. We will focus on cancer care, elderly care, and telehealth. We have some fantastic speakers from both the United States and Sweden, and our great moderator, Julia Manchester from The Hill, will guide us through the discussions. In the concluding part of the forum, we will have 3 breakout sessions on these topics to allow for more in-depth discussions. But let us now turn to 3 introductory speakers. First, it's a great honor to have our Minister for Health and Social Affairs, Ms. Lena Hallengren, with us today. After Minister Hallengren has given us her remarks from the Swedish perspective, we are excited to welcome the Director at the Office of Global Affairs at the U.S. Department of Health and Human Services, Ms. Loyce Pace, who will give some insights from the U.S. perspective. And finally, we will hear from Ms. Maria Helling, CEO of the Swecare Foundation, who is representing the almost 20 Swedish healthcare and life science companies that are part of Minister Hallengren's virtual delegation. So first, Minister Hallengren, I know it's been a very busy year for you, and we are really looking forward to hearing your thoughts on the important topics we are discussing here today. So please, Minister Hallengren. Good morning, everyone, and welcome. It's such a pleasure to virtually welcome you here at the House of Sweden in Georgetown. Of course, I would have wished you were here live. I'm sure we will be, but right now we have to settle for virtual. We're right by the Potomac River here in the wonderful Washington, D.C., and we are nearing one of the most beautiful times of the year, the cherry blossom season. Well, so thank you all for tuning in to today's seminar on the topic of life science. I think in our lifetime, there has never been such an interest in life science and healthcare. We have all followed the news closely on how vaccines and medicine are developed and tested, and how healthcare systems and healthcare workers have been stressed, and the need for international collaboration and innovations. We are learning new things every day. The title for today's seminar is Transforming Healthcare to Opportunities. Besides all the challenges, the pandemic has provided us with a unique opportunity to redefine healthcare. So in the seminar today, we will focus on 3 life science and healthcare topics, how they have been impacted by the pandemic and opportunities ahead. We will focus on cancer care, elderly care, and telehealth. We have some fantastic speakers from both the United States and Sweden, and our great moderator, Julia Manchester from The Hill, will guide us through the discussions. In the concluding part of the forum, we will have 3 breakout sessions on these topics to allow for more in-depth discussions. But let us now turn to 3 introductory speakers. First, it's a great honor to have our Minister for Health and Social Affairs, Ms. Lena Hallengren, with us today. After Minister Hallengren has given us her remarks from the Swedish perspective, we are excited to welcome the Director at the Office of Global Affairs at the U.S. Department of Health and Human Services, Ms. Loyce Pace, who will give some insights from the U.S. perspective. And finally, we will hear from Ms. Maria Helling, CEO of the Swecare Foundation, who is representing the almost 20 Swedish healthcare and life science companies that are part of Minister Hallengren's virtual delegation. So first, Minister Hallengren, I know it's been a very busy year for you, and we are really looking forward to hearing your thoughts on the important topics we are discussing here today. So please, Minister Hallengren.
Thank you for your introduction, Ambassador, and good morning, USA, and good afternoon to our Swedish delegation. Even if I wish we were able to join you in person in Washington, D.C., I'm very excited to be part of this virtual high-level forum. Thank you to everyone who made it possible, and an even greater thanks to all participants to taking the time to listen in. Before I start my remarks, I just wanted to give a quick presentation of the business delegation I have with me. They represent the Swedish healthcare sector, private companies working with cancer care, elderly care, and telehealth, and you will hear more from them in the breakout session later. The United States is an important partner to Sweden, politically, but also as a trading partner. The US is Sweden's largest export market outside Europe, and Sweden is the 13th largest investor in the United States. Life science companies is one important sector in this trade relation. The pandemic has proven that we must build new partnerships and find creative ways for the public sector, the private sector, and academia to cooperate to be able to create robust, innovative, and resilient healthcare systems for the future. And please allow me to touch upon some of the areas that will be discussed here today. Sweden has one of the world's best elderly care systems. We allocate around 4% of our GDP to long-term care and also provides the highest number of healthcare workers for the elderly. However, the outbreak of COVID-19 has highlighted weaknesses in Swedish elderly care. The government has made a historically large increase in support for the elderly care sector that will strengthen both the staffing situation and quality in care homes for elderly. A special investigator, Olivia Wigsell, Director General of the National Board of Health and Social Welfare, has been commissioned to propose a new elderly care law, and you will hear more from her later in this session. Cancer care in Sweden has got medical results and good medical results and is developing rapidly in terms of diagnostics, treatment, and use of digital support. The 10-year survival has, according to the National Board of Health and Welfare, improved significantly and was in 2018 estimated to be 69% for both men and women and about 85% for children. Thanks to well-structured cancer care, Sweden has been able to maintain most of its urgent service during the pandemic. But one of the greatest challenges has been the failure among the population to seek care. The number of diagnosed cancer cases has fallen quite clearly during the last year, and at the same time, we know that these cancer cases exist, but they are undiscovered. So what role can primary care play in early detection? How can AI and precision medicine support more efficient cancer care throughout the patient journey? These are all questions that the pandemic has shed a light on, and even though they most certainly were relevant long before. During the pandemic, we've done a few changes in the effort to keep screening participation rates as high as possible. One such change is the use of HPV self-sampling. The Swedish government has made an agreement with the healthcare providers, the regions, to explore the use of AI in cancer imaging to increase efficiency as well as quality. And that brings me to the digital transformation of healthcare systems. It is my firm belief that the healthcare of the future must be accessible and affordable by everyone, and to a large extent that will be digital. This is something that we will achieve by enhancing innovation, research, collaborations, and by working together across countries and sectors. Sweden is aiming at being among the best in the world at using the opportunities offered by digitization and e-health to make it easier for people to access both good and equal health and welfare. During the pandemic, we've seen a sharp increase in the usage of digital services. There has been an exponential increase in digital healthcare visits during the spring 2020, both in sparsely and densely populated areas. And I understand that this is the case for many caregivers in the US as well. The Swedish healthcare sector has been quick to adapt and incorporate digital tools. We have almost 100% coverage of e-prescriptions and using electronic health records. However, even though Sweden have come a long way, we're not satisfied. We hope that dialogues like this forum can guide us in how to make the best use of modern technology. I'd like to end my remarks by saying a few words about COVID-19. Just like all countries, the goal for Sweden has been to limit the spread of the infection in order to save lives, protect public health, and ensure that health care resources are available. We are tackling the COVID-19 pandemic through both legally binding measures and recommendations. Measures are regularly being evaluated, fine-tuned, and have been adjusted based on expertise and lessons learned. Each country has respective national circumstances, including legislation and the organization of our public health care systems that make up the foundation for our interventions during the COVID-19. Sharing experiences and best practices is so important. During the COVID-19 pandemic, we've witnessed new medical products being developed and an unprecedented pace. The same speed with which new and safe vaccines against COVID-19 were developed must now be applied to develop new, safe and effective antimicrobial products and practices to prevent antimicrobial resistance, AMR. AMR is without a doubt one of the greatest challenges to the 2030 agenda. My hope is that the global leaders group that I have the honor to be a part of will enhance global coordination and act as a catalyst for collaboration. And to conclude, Sweden and the US are both ranked among the top 10 countries in the world when it comes to healthcare expenditures and research and development. So let's use this opportunity to build an even closer dialogue between policymakers, companies, and other stakeholders in the life science and healthcare sector. And now I'm happy to give the floor to Director Loyce Pace from the Office of Global Affairs at the US Department of Health and Human Services. Thank you for joining us today. Both I and the Swedish delegation of healthcare is looking forward to learn about the US policies and plans. Thank you.
Well, thank you very much, Honorable Minister, as well as Madam Ambassador. I'm grateful for the invitation to speak to you all this morning, and I join you in hoping that we will once again be together soon. I'm also glad to be representing the US government today, especially in light of previous collaborations that we've had with the government of Sweden through the OECD Health Committee and otherwise across a range of topics, including those that we are covering as part of this seminar. I also join you, Honorable Minister, in recognizing that there are a number of lessons that we can learn from this pandemic that apply not only to outbreaks or pandemics themselves, but also to the range of issues that our citizens face across health and healthcare. So I'm grateful that you all are taking a wider lens or view with regards to what we can do in the wake of COVID-19. And my remarks are going to be centered in much the same way, really talking or thinking about how the US is responding on cancer, elder care, and digital health throughout the pandemic. For those of you who might not know, I have a history myself in cancer and public health specifically, and I have been concerned about other health issues that have suffered or otherwise lagged behind in the wake of COVID-19. I have friends who are facing cancer treatment now and who have been concerned about their access to care. And you can only imagine how that has ripple effects across individuals, families, and communities when it comes to something as serious as a cancer diagnosis. Also, I'm sure people are aware that the vice president, or that the president, currently the then vice president, Biden, has been very vocal about his own cancer story. And when he was vice president, was able to launch the Cancer Moonshot Initiative, and that work does continue. We're happy that Sweden has supported those efforts as well through a special consortium. But in light of what COVID is doing to sort of put access to care at risk for many people in our country, I think that it is important that we continue to track the rates of screening and treatment that we know is at risk of dropping and has been reported to have dropped in this past year. I think we'll need to continue monitoring that situation to ensure that people who have a cancer diagnosis or who are living with cancer without knowing it are made aware of that so they can seek that healthcare as soon as possible. But there are some lessons learned in the pandemic, as I've said, about opportunities for us as well. And I'll get a little bit more into this when I talk about telehealth, because there are opportunities to virtually engage with patients about screening, for example, and educating them about screening, as well as the opportunity for home-based testing with regards to screening, particularly colorectal cancer screening, and opportunities for us to increase access to those innovations in a way that keeps people safe, but also keeps people healthy. On the subject of elder care, though, there's something else that we have recognized in the pandemic, how at risk our elder community truly is. And it goes without saying that whether we have been concerned about one's risk for COVID or access to treatment and now a vaccine, that has been a population that we have paid special attention to here in the US. And so we are very much focused on how we can apply the principles of person-centered care to this population. And we actually have an initiative whereby we are wanting to ramp up what we're calling age-friendly health systems for this community, so that we have a healthcare system that serves everyone here in this country across the lifespan, but particularly in their elder years. We also, as a result of this pandemic, have uncovered issues with our long-term care facilities here in the US. And so we are very committed to ensuring a higher quality to those long-term care facilities so that they can be responsive to the needs of their communities, not just in a pandemic again, but across a range of healthcare issues and risks. And then finally, as I mentioned, I would come back to digital health and the opportunities we see there. And I think that over this past year, I know that I have worked to uncover or identify silver linings in a pretty dark time. And it's been important for us, I think, to recognize all of the opportunities we have with digital health and specifically telehealth and telehealth services. Now, an important caveat to that is the risk of whether those very services are available to people equitably or equally. There are some very real health disparities when it comes to telehealth that I would be remiss not to acknowledge, whether that's with regards to geography or connectivity, one's income level, or access, other economic access to tools and resources, let alone literacy, disability, and other considerations. So we'll need to be sure, and what we've learned in this past year is how to be more flexible with those digital health tools. For example, by creating audio-only options, and otherwise recognizing how we might create barriers or other hindrances to access to care, particularly using these platforms. But it's quite promising to think about how these services can be expanded, working with our partners in industry, but also community-based organizations. And what we can build on is how we have used these very tools for COVID-19 itself, whether that's with regards to risk education and mitigation, contact tracing, communication of test results, let alone some of the more systemic issues such as supply chain management, vaccine management and tracking, and the like. So with that, I am again very grateful to have addressed you this morning, but more importantly to engage with the government of Sweden on these and important health issues. And with that, I will return the floor to our co-hosts. Thank you again.
Well, good morning and good afternoon, everyone. It's really a great pleasure to be here with you today. My name is Lena Hallengren. I'm the CEO of Swecare Foundation. That is one of the organizers of this event. And Swecare is an organization working for the internationalization of the Swedish healthcare and life science sector. We work very closely with the Swedish Ministry of Health and Social Affairs, with the healthcare sector itself, and also with the industry. We know that last year was extremely tough for the healthcare systems, of course, for all patients, families, people affected by the pandemic, but also for our companies and organizations that are in internationalization processes. Of course, to establish new contacts, to maintain your contacts is so hard when you cannot travel and you just cannot meet like we're used to. So that is why we are arranging these kind of events that we're here for today. And we are so very happy for this opportunity to meet with you all who have chosen to participate and to be able to discuss important challenges and to share our experiences from both sides. We are here, it was mentioned, with a virtual delegation, could say. We are visiting the US for a couple of days. We're having meetings with different organizations and interesting counterparts. The interest from the Swedish side has been great. We're, I think, about 30 different companies and organizations in this delegation. And these different actors, they represent all possible aspects of the Swedish healthcare sector. And all of them have interesting ideas and solutions that can improve healthcare and also improve accessibility of healthcare for all our citizens. I would just once again like to thank everyone who is here and who is participating for their time and their effort in this. Please take the opportunity to connect with the people you find interesting, and make sure you have contact details so that we can continue the discussions even after this forum ends. With those words, I hand over to today's moderator. That is Miss Julia Manchester. Over to you, Julia.
Good morning, everyone. Thank you so much to Ambassador Olofsdotter, Minister Hallengren, Director Pace, and CEO Helling for those opening remarks. You know, clearly this coronavirus pandemic has really wreaked havoc on our lives in Sweden and in the United States. And as more and more people get vaccinated, I think we're starting to see a light at the end of the tunnel. But that leaves us with the question as to how this pandemic really impacts the future of healthcare, both in Sweden and the United States, which we all know have very different healthcare systems. So to start off with, we're going to talk about 3 different topics. During the 3 panels, we'll focus on these 3 topics: cancer, elder care, and telehealth. Cancer is the second leading cause of death globally, and the COVID-19 pandemic has only exacerbated that situation. Many screening programs have been put on hold, and fewer patients are seeking care, resulting in a cancer care backlog and an increase in the number of late-stage presentations of cancer. So for our first panel, I'd like to introduce Professor Hans Haglund from the Swedish National Cancer Care Coordinator and the head of the Zero Vision Cancer, and Dr. James H. Dorshow, the director at the Division of Cancer and Treatment and Diagnosis at the National Cancer Institute. Welcome to you both, and thank you so much for taking the time to come and speak at this panel. You know, I'm going to give the floor to you first, Dr. Haglund, to see how you feel about this pandemic and really the impact it will have on cancer care going forward.
So thank you very much. Your Excellencies, ladies and gentlemen, I'm delighted to take part in the Swedish Digital Healthcare Delegation to United States of America. Solving global societal challenges like cancer and COVID-19 pandemic requires research, innovation, and cooperation. Through our long history of trade and cooperation, Sweden and US have built a solid friendship. And what could be a better way to honor that friendship than to share knowledge and experience and to explore new opportunities for further cooperation. Together, we can redefine healthcare. First, I would like to give a short introduction on the ongoing Swedish cancer strategy. In our country during the past 40 years, due to increased life expectancy, we have seen an increase in number of citizens diagnosed with cancer, while at the same time mortality has dropped. For many forms of cancer, this means an important shift from a mortal to a chronic disease. A coherent and standardized care process without unnecessary lead times and a good interaction between patients, relatives, and care provider is therefore essential to the patient's well-being and the outcome of care. For more than 10 years ago, in 2009, Sweden adopted a national cancer strategy. The strategy set up 6 regional cancer centers for knowledge management. This kick-started the development of a more patient-focused, accessible, and equitable cancer care. Thereafter, standardized care processes, national guidelines, the concentration of highly specialized treatments, and new therapies have been developed and introduced into cancer care. Today, in Sweden, 85% of children with cancer and 70% of adult cancer patients are long-term survivors. In order to make cancer a curable disease, survival needs to improve by 15% and 30% for children and adults respectively. By developing precision diagnostics, precision treatment, there's a great chance that this can be achieved. There are many reasons behind the Swedish good achievements in cancer care, and they are all interconnected. The cancer care is free for all. Healthcare in Sweden is a public responsibility and largely tax financed. The Swedish approach to cancer care is rooted in a long tradition of close collaboration between healthcare, academia, and the industry. An active public health policy to prevent lifestyle-related diseases, screening programs, advanced tools for diagnosis, as well as using the latest available technologies in different cancer treatment modalities, and the involvement of patients in the development of cancer care are all important factors for successful outcomes. The standardized patient pathways, clinical guideline, national quality registries, and multidisciplinary cancer management are other contributing factors. Approximately 1 year ago, the first COVID-19 patient was diagnosed in Sweden. The COVID-19 pandemic has since then affected large parts of healthcare and the society. The assessment so far in Sweden is that cancer care has worked well and been a priority. For example, has the waiting times for cancer surgery been decreased during this pandemic? The huge challenge is that fewer individuals have sought treatment and fewer have participated in screening programs and in clinical studies. There are differences between different tumor forms and regional difference in decline. At national level, between January and October 2020, our latest reports show that 9% fewer tumors have been diagnosed as compared to the same time period 2019. This corresponds to 5,000 to 6,000 undiagnosed cancer patients during the first 8 months of the pandemic in a population of approximately 10 million people. The largest percentage decline is in prostate cancer with 20%. The short-term consequences of deficit from newly discovered cancer depend to a large extent on the contingent development of the pandemic. For some regions and diagnoses, there is a risk that different parts of cancer care will experience a clearly higher burden when the pandemic subsides. Long-term consequences on cancer survival and mortality are not yet accessible. For some cancer, the negative effects of delayed diagnosis are negligible, but potentially more serious for patients with lung, head, neck, and colorectal cancer, for example. The Confederation of Regional Cancer Centers has appointed a national group that monitors the development and effect of the pandemic to highlight future effects for patients and cancer care. And so far, 3 reports on deferred cancer have been published. Both US and Sweden have come a long way in regards of cancer care, but there are still challenges, but also opportunities. When I took over as the National Cancer Coordinator in March 2019, I saw a need to strengthen cooperation to better integrate cancer research and innovation into healthcare. I invited to a meeting, and that later became the starting point of the innovation hub Vision Zero Cancer. This was done together with AstraZeneca, Elekta, and Stockholm School of Economics, among others. Vision Zero Cancer is a unique milieu for research and innovation, connecting people and organizations from different backgrounds and competences, disciplines, and the industry, all wanting to move from today's isolated initiative to a greater cooperation, all driven by the same vision, that no one should die because of cancer, and that more cancer patients should live longer and feel better. We are going to transform cancer from a deadly to a curable or chronic disease, but there is no single answer as to how. What we know is that no one can do it on their own, and that we need to think in new ways. Finally, the pandemic has tested the healthcare system around the world, but also created a unique opportunity to redefine cancer care. We know that we are not going to go back to normal, but forward to a new normal. The new normal is something we will have to build together. And what better place to start than right here today? Thank you very much.
Thank you so much, Dr. Hagland. I'm certainly hoping the new normal is definitely around the corner. It's great to get your perspective from Sweden. Now I'd like to go to our second speaker from the United States, Dr. Dorshow from the National Cancer Institute. Doctor, take it away.
Thank you so much for the opportunity to address this panel. Just to remind everyone that in the United States, the National Cancer Institute is primarily a research organization. And so the impact of the pandemic has been across the board on many of our research endeavors, from the area of screening and diagnosis to cancer clinical trials, to the impact of the pandemic and COVID-19 on cancer patients per se. So I'd like to address briefly each of those areas and to give you some sense of what we're doing in the research area to try to address those interactions. So first of all, we are pleased to have a pretty large network of organizations around the United States that track and model the incidence of cancer and outcomes for a variety of diseases. And using that network, a few months ago, results became clear that for breast cancer and for colorectal cancer, the screening efforts across the country, especially in the months of April through September, had dropped by somewhere between 40 and 50%. Really a dramatic and quite unfortunate decrease in screening for those important diseases. What we've been able to do is to try to model the impact of that decrease in screening on the long-term outcome of those diseases in the US, and it is really quite disturbing. We estimate that over the next 10 years, tens of thousands of men and women who were not screened during the depths of the pandemic will lose their lives because of this missed opportunity. And so this has spurred a significant additional research effort to try to find out ways to motivate individuals to resume screening, to make them easier to use handheld devices, but actually to really develop a research strategy to enhance screening, to try to bring back individuals who would normally have undergone the appropriate kinds of screening across the board into our systems. So I think that it is likely, given the rapid rate of vaccination in the U.S., that over time we'll recover our screening rates. But I think that it's likely that over the next decade, we will be able to, unfortunately, follow a cohort of individuals who were quite dramatically impacted because screening was either not available or the individuals chose not to undergo their screening on a normal process because of difficulties accessing their providers. The second area that we have tracked quite carefully is the impact of the pandemic on a very large clinical trials program that the National Cancer Institute in the U.S. supports. We basically support somewhere between 40 and 50,000 patients a year going on various cancer clinical trials. And what we found is that beginning exactly a year ago, that there was an enormous decrease, basically a decrease of between 40 and 50% of accrual to our most important large randomized trials that change the state of the art for cancer treatment. And what happened is that because of the pandemic, these activities were de-emphasized in academic medical centers and cancer centers across the country. And so in response to that, and very quickly, we made a number of changes to our entire clinical cancer research program to try to facilitate the ability for individuals to undergo their treatment and to go on clinical trials without having to travel as far to major medical centers. And this effort included not only increasing our telehealth capacity, but also shipping investigational drugs to local venues, to decreasing the burden of auditing clinical trials, to basically making it easier for individuals to access their treatment without having to interact in ways that were more difficult. And those efforts, I'm happy to tell you that beginning in the early to late fall of 2020, led to an increase in our accrual so that by the time of the first of the year, we were back up to the same level of clinical trial accrual that we had been in January and February, all because of very rapid changes enacted by the systems that we oversee, but also working hand in hand with the U.S. FDA. And I think that we are now in the midst of a program to try to evaluate all of those changes and to understand whether we should, and we think we should, make many of those changes permanent to enhance the ability to accrue patients in rural areas, to enhance the ability to accrue patients in underserved areas, and simply to make it easier for patients to go on studies that we think have a good chance of improving their overall outcome. The last point I'd like to talk about is what we've done vis-a-vis to try to increase, from a research perspective, what our understanding is of the effect of COVID-19 on patients with cancer. And this is something that has been a major effort, and we began again, almost about a year ago, to start to develop a national trial that was opened in about 6 weeks, began in May of 2020, which has now accrued 1,000 cancer patients across the United States at something like 900 sites, where we are attempting to understand the long-term effects and the interaction between COVID infection and treatment for various cancers, to understand the specific types of cancers for which the COVID virus has the most adverse effects, and actually to understand the long-term impact of infection on the ability to get treatment and the impact of the virus on the efficacy of that treatment. We're actually well into this study and almost completed with our accrual. And what we know already is that COVID infection has a tremendously adverse effect on patients with hematopoietic diseases, that is to say, lymphomas and leukemias. There's no doubt that their treatment cannot be delivered as safely, and that when they are afflicted with the COVID-19 virus, their outcomes are substantially poorer, that not only than the compared against the overall public, but also other forms of cancer. And so we're looking very specifically at ways to try to enhance the vaccination rate in specifically those types of patients as well as others. And so I really wanted to thank everyone for the opportunity to share that impact with all of you, and to make it clear that this is an enormous problem that I think is going to be with us for many years, actually looking at the overall impact of how the COVID-19 pandemic affected cancer care and outcomes in the United States. Thank you.
Dr. Dorshow, and I want to pose a couple of questions to both of you. First, we talked about how this pandemic has caused a cancer care backlog, and that's really impacted a lot of patients in the U.S. and in Sweden trying to seek care. And I want to go first to you, Professor Hallengren. What do you see as the immediate and long-term remedies to fix this backlog?
Well, it's a really good question, and I think in the short run or immediate remedy are that we have to increase the information campaigns to the general public to visit healthcare. If symptom, visit healthcare and participate in planned screening program. But we also have to continue to start up the screening programs that have been closed or on lower activities. One way to reduce the risk of getting COVID in contact with the healthcare could be that making the first appointment digital. And at least in Sweden, it is of importance to continue our strategy with using the standardized patient pathways and also using the national clinical guidelines. But in the long term, I think we have to still continue to prioritize patients with greatest need for care, increase the collaboration within and between our 21 regions in Sweden. And we also have to continue with digital follow-up clinics, which has started already and are used very much more than previously. And also it is of importance to follow up and evaluate the effect of COVID. I think those might be the most important. Thank you.
Absolutely. And Dr. Dorshow, I have the same question for you, but I'd just like to add, I guess unlike Sweden and the US, we obviously don't have a nationalized healthcare system, and we've seen that the ways different states have responded to the COVID-19 pandemic and their own healthcare systems have responded just differ greatly. So how do the differences across the country impact how we're able to remedy this backlog?
So I think these are very substantial questions. So one of the things that we've tried to do is to reach the medical community through a fairly extensive outreach campaign, publications for cancer patients to try to enhance their priority for vaccination. We know that this is really critical. And the NCI has made a major effort across the board at the state level with state cancer societies, as well as at a national level from a significant public outreach campaign to try to make it clear that we think that cancer patients should go to the head of the line in terms of who gets vaccinated everywhere.
Absolutely. And Professor Hallengren, what do you see as the most important way to have a person-centered cancer care?
Yeah, well, I think first the cancer care has to be developed in collaboration with the patients and their relatives. And a person-centered cancer care culture has to be developed in the healthcare. Everything from information, education, and design of studies. We also have to be more active in measuring and monitoring patient-related outcomes. discuss the outcomes with the patient and ask the patient what is important for you, but also engaging patient in managing their care, everything from prevention, physical activity, compliance to treatment, etc. But I also think that it might be so that practical guidance on the implementation of person-centered cancer care could be of importance.
Right.
Thank you.
And Dr. Dorshow, finally to you, what do you think cancer care in the future, like in 2030, roughly 9 years from now, what's it going to look like?
I think that one of the things that really hasn't come up to be talked about today really is if you look back 20 years to see what was the standard of care, how patients were managed, what was required, the kinds of treatment that were necessitated, and the efficacy of those treatments, and compare that today, it really is a revolution. And at least in my lifetime, it's practicing on medical oncology and the treatment of systemic disease today is nothing like it was. And if you just, it seems incremental, it is incremental, but if you take it over a decade or two and think about what we couldn't do then and what we can do now, based on our understanding of the molecular biology of cancer, and as that really exponential understanding of the basic science increases, I'm extraordinarily hopeful that better treatments, more focused treatments, more targeted treatments will continue to be the way forward for diseases that today are routinely treatable, that really in my career at one time were untreatable. And that really is based on the science and the application of the science.
Absolutely. Well, after talking to both of you, I feel very hopeful about this subject matter going forward. Thank you to you both for sharing your incredibly valuable insights. We appreciate it. Before we start our next panel on elder care, we're actually going to watch a short film on Swedish life, a science and success story. Great. Now we're going to shift gears to talk about a topic that has really impacted a substantial part of the population in Sweden, the United States, and around the world during the pandemic, elder care. We know that elderly populations have faced risks to being out in public and interacting with others due to the coronavirus and the risk it poses to their health and mortality. However, it's also posed a huge risk and impacted them greatly when it comes to the topic of isolation. We know that elderly people in the US, Sweden, and around the world have been remaining isolated until they've recently been vaccinated. So I'd like to introduce our next speakers for this panel. Our speakers are Ms. Olivia Wigzell, Director General at the Swedish National Board of Healthcare and Welfare and recently appointed chair of the Inquiry on New Legislation on elderly care, and Dr. Tricia Newman, Senior Vice President at the Henry J. Kaiser Family Foundation. Welcome to you both. Ms. Wigzell, I'd like to start with you.
Thank you. Thank you for the floor, and hello to everyone, dear colleagues. I'm happy to be here today to speak about elderly care and elderly during the pandemic. I can only agree with what Minister Hallengren has said earlier about elderly care and the Swedish healthcare system that has proved to be sustainable during the crisis. But I'm here today to talk about our Swedish experiences from COVID-19 and elderly care. A mapping of deceased from COVID-19 in Sweden shows that the largest risk factor is age. A majority, 72% of all deceased in Sweden has been 80 years or older. During the spring of 2020, nursing homes was hit hard by COVID-19. A nursing home in Sweden, that is a form of housing for fragile elderly persons. The medical and social needs are big and care staff is available 24 hours a day, but it's not a hospital or institution, rather it resembles a home environment with great respect for personal integrity and self-determination. Mortality generally is higher for people living in nursing homes. On average, you live there for 2 years. However, in 2020, the mortality increased prominently. And the high mortality rate in nursing homes has not been unique for Sweden. The large share of deaths among fragile elderly people is in line with observations made from many other countries. 35 to 75% of all COVID-19 deaths has occurred in care home residents. So it's actually in every country a high number. In Sweden, this group has been prioritized for vaccination, and we are now starting to see great effects from that. The mortality rate for elderly in care homes is declining, and nursing homes are now all over Sweden open for visitors. But the pandemic has exposed the structural shortcomings that exist still in the Swedish elderly care sector. They have had an impact on illness and deaths from COVID-19 in Sweden, and they have been known for a long time, actually. Examples of those shortcomings are inadequate level of expertise among staff, shortages of doctors and nurses, lack of continuity, and working conditions. Deficiencies in coordinated documentation and leadership should also actually be added to the list. And adherence to basic hygiene standards is something we still struggle with, but it's also somewhat a success area in Sweden because we rolled out a national web-based education for healthcare workforce early in the pandemic, and it has participants from all over Sweden from all 290 local communities in Sweden. But we have much work left to address these structural shortcomings. In Sweden, the government has committed to strengthen elderly care by increasing, for example, funding to municipalities, by offering subsidies to increase the medical competence among staff. New and existing healthcare staff can educate or further educate themselves during paid working hours. Another example is what Minister Hallengren has mentioned, the Commission for an Inquiry for a new law for the care of the elderly. The aim is to elucidate the national mission to elderly care and to increase the quality, for instance, by ensuring good access to medical expertise. And I'm very proud to lead this important work. The law will contain a national quality of care standard, which can be a support for actors that conduct elderly care and provide a guidance when supervising elderly care. Aspects of quality that are of importance, to mention a few, is the right to an active life, to continue to invest in prevention and health promotion, safety and safe care, personalized care, influence over one's everyday life, continuity, support to the family and those who are close to you, and of course, access to welfare technology and e-health solutions. The shortcomings is of course something that will form the new legislation, but another base for the legislation is of course all the possibilities we have in our welfare sector and our elderly care sector. And that is the possibilities that come with new digital solutions and with possibilities to self-monitor your chronic diseases, to invest even more in health promotion and prevention. And we have been doing that to a high extent in Sweden, and we have now, after the age of 65 years, we can expect even 10 more years without any effects on our daily functions, and 15 years without being affected in our daily ability to manage our lives. And then it will be followed by a couple of years where you have where you're in need of support, and also all the possibilities that come with new welfare technology that we are rolling out now in high speed in Sweden. So there's a lot to be gained when investing in health, functionality and user-friendly technology. And it enables, of course, in the end, the elderly to manage their everyday life, but it can also have economic benefits on a societal level. And I look forward to discuss how we can invest in the elderly care sector onwards during the breakout sessions. Thank you.
Thank you, Ms. Wigzell. I'd like to go now to Ms. Tricia Newman from the Kaiser Family Foundation.
Join you in person, and maybe one day we'll have this conversation in Sweden. If I can just imagine traveling one more time again, that would be great. I'm particularly pleased to be here because you've chosen such an important topic for this panel. Because older adults in the US, as in Sweden, as we've just heard, and in other countries, have borne the consequences of COVID disproportionately. And while I confess to having no real expertise in the Swedish healthcare system or long-term care system, I've read just enough, and I've heard this morning enough to know that we face some common challenges and we face common opportunities. And I am a bit of an optimist in thinking that these challenges are ones that we can tackle to improve the lives of older people, both in the United States and in Sweden. The only silver lining of this horrifying year is that COVID has exposed a set of challenges that have longed for attention, creating a long-awaited opportunity to reimagine how we provide care and improve the quality of life for older adults who are unable to care for themselves. These challenges are a little bit different than the ones we heard about in the earlier sessions with respect to people who didn't get preventive services that they needed or may not have gone to the hospital and didn't get early detection of conditions that require serious attention. I'm really focusing on people who are unable to care for themselves. Their needs are less medical and more day-to-day management of their daily activities of things they can't do. Similar issues, I should say, arise for people with disabilities who are not yet elderly, and whatever applications that we are applying to the elderly population, hopefully we can learn to do the same and apply them more broadly to the population of people with disabilities, which is not an insignificant number in the US. So we just heard some numbers in Sweden, and I'm going to give you the US counterparts. Older adults were disproportionately harmed by the pandemic, and among them, older adults from communities of color in the United States were especially hard hit. People 65 and older account for 80% of all COVID deaths here in the United States, and about half of all COVID-related hospitalizations. Nursing homes and assisted living facilities were at the epicenter of this tragedy. About 1/3 of all deaths in the United States occurred in long-term care facilities. That is both nursing homes and assisted living facilities, and that's also residents and staff. So that is really where as I said, the epicenter of the problem, and also suggests opportunities for how we can make improvements. There was also the more intangible consequences, which is the mental health of people who were living in nursing homes and other facilities who didn't have access to their family members, which not only affected, loneliness, social isolation, and depression, but often in nursing homes in the United States, at least, and other facilities, families help supplement the care that's provided in nursing homes. So family members were very stressed out that they weren't able to come join their loved ones for meals because they knew that was the best way to make sure that their family members could eat. We're still trying to understand what the effects of that are, but in the fall of 2020, we released a study showing about a quarter of older adults reported anxiety or depression in the midst of the pandemic. That's not the nursing home population, but that may be their family members and friends at home. And as I said, the children and the partners were deeply affected because they had anxiety about what was going on inside nursing homes, particularly when telecommunications was lagging and it was hard to get real-time information from the staff, because often the nursing homes in the U.S. are struggle with being understaffed, and that was a serious issue during the pandemic. So in many ways, the tragedy here unfolded in ways that were both predictable and predicted. Nursing homes are congregate settings where residents and staff are in close proximity, making it easy for the virus to spread. Nursing homes are often staffed by low-wage workers who work in multiple jobs. They have part-time jobs. They travel to work on public transportation. They live in multi-generational households. Many are not given sick leave, so they can't afford to take a day off, even if they fear they may be sick and therefore contagious. In the early months of the pandemic, there was inadequate equipment, PPE, inadequate testing, and also inadequate real-time guidance to the staff, the medical directors and the nurses in facilities. So they really didn't know what to do. And if you talk to some of the nursing homes in the United States, the directors who were hit early on in the spring, they really were kind of trying to figure it out on the fly because there wasn't a way of providing current good information about infection control and what to do to protect the staff. So that's a lot of bad news, but we really have a good news story here, as you have in Sweden. Nursing home deaths have plummeted since the introduction of the pharmacy partnership program, where the federal government partnered with pharmacies to bring vaccinations to staff and residents as quickly as possible. I'm not showing slides today, but if I did, I'd show one where there's sort of a V, like a steep V curve, where the bottom would be the drop in nursing home deaths. My bottom hand here would be the drop in nursing home deaths that occurred immediately after the vaccination program started, while my top hand would show the trend among other people. Since then, we've also seen a similar drop among the general 65 plus population, not just those who are in nursing homes. So we are seeing a good news story in the United States, and that is really very comforting after a very long and difficult year. So as I mentioned, I feel that this crisis has created an opportunity, an important opportunity to reimagine how we're caring for our oldest and frailest parents and grandparents. And I think there's a range of things that could be done and are starting to be done, both pragmatic changes and more systemic changes and structural changes that could have a big impact. So one is, and we just heard earlier about age-friendly living. We've learned that the larger facilities in the United States generally were the ones that were hit the hardest in terms of cases and deaths. So one thing we might think about is building smaller settings where there are fewer beds, fewer opportunities for infection to spread, and creating environments where people want to be, where they want to live, and they have sufficient staff oversight to take care of them. So speaking of staff, I do think what we have learned is there's more that needs to be done to invest in staff, to invest in a more professional workforce to care for our aging adults, with an investment that leads to job satisfaction and continuity, in contrast to the current environment where we rely heavily on workers who are lower wage, often part-time, and tempted by easier work that they can do in other settings for a few dollars more per hour. So I was interested to hear about the efforts in Sweden, where there's an effort to educate staff who are working in nursing facilities during paid time, and some of that is occurring here in the United States as well, so that people can feel invested in their work. And there's also perhaps an opportunity, particularly if we have smaller living situations. There's a greenhouse movement here that's of interest, where there's more autonomy in the caregiving, and therefore the staff are less constrained and feel like they really are taking care of their residents and have eyes on their residents, and there's not so much turnover. Other things that we might think about, as I said, I think nursing homes initially were caught off guard without the expertise or tools or technology or PPE to put a stop or at least block the virus from entering their door and spreading down the halls from room to room. So I think what we've learned is we do need better tools for infection control. So we need tools, we need standards, and more oversights, and that seems to be a big issue at least here. We need more training, not just for the aides that are working in nursing homes or doing sort of daily caregiving, but also for the medical directors and the nurses who are running the facilities. Many medical directors in the US are not actually trained in geriatrics. So perhaps more training from top down would be a useful enterprise. I think another area for another opportunity is architecture, not just in creating smaller age-friendly spaces, but maybe there's something more that can be done through architecture to create a safer environment, kind of moving a step beyond where we are today. And, I sort of challenge the architects who are thinking about this to move us to the next stage to create better environments. We've heard a lot about telehealth, and I think there was some investment in telehealth during the pandemic, much more so than before the pandemic. And I think this is an area where there can be a major investment in efforts to help keep our older people out of hospitals and out of the emergency room, which happens so often because there's not skilled caregiving in the nursing home in order to stop them from taking place. That's not necessarily related to COVID, but it certainly seems like a good idea. Standby reserves for PPE, and other equipment. And I think also we need to totally revisit the way we're measuring quality, since the quality standards that we used didn't seem to be a good proxy for problems during the pandemic. Some of the ideas in the US run up against the attention that we have here, and perhaps they have in Sweden, which is this tension between wanting to support innovation and allow private investment and allow owners to do what they can creatively in order to improve the quality of life for people in nursing home residence. That butts up against the notion of regulation, because, and by that I mean regulation to protect our most vulnerable citizens. We have a tension in the US, and I think that's going to play out in the next few years, because I think there is concern that there's not sufficient protection for people, because we've seen what has happened. And yet we know that private equity is very much involved in nursing homes and assisted living, and there's a movement toward assisted living and other residential facilities where there's less regulation. So I'd like to wrap up with two broader thoughts. One is, while we're talking about nursing homes and other facilities, there is a great need to do more for people who are living at home and need support because they're unable to take care of themselves. So I can imagine tapping into new resources, not just telehealth and other ways of communicating digitally, but also using other services in the community in a more systemic way, to help with transportation, help with pharmacy, help with meals, and then help monitor and educate people who are living at home and don't have access to information that maybe others have. And then the second sort of idea I'd like to plant is we do have a fragmented system. We have a federal government, we work with state governments, and we also have separately a public financing programs, Medicare and Medicaid, and separately we have our public health infrastructure, which is federal and downstate and local. I think what we have learned during this pandemic is a need to pull everything together in order to respond effectively to a national emergency. We're still a bit siloed, and having better tools, data in particular, to work better with each other in order to address needs rapidly, I think would take us a lot further. So this has been a very hard year for older adults in our country and in Sweden and families. And I hope we learn from this experience, because I think we're all about improving the health and quality of life for our older parents and grandparents during pandemics and other times.
Well, thank you so much, Ms. Newman. Now I'd like to go on to a question and answer set series. First to you, Ms. Wigzell. What can we learn from the pandemic when it comes to the challenges of improving elder care and opportunities that have maybe arisen during the pandemic in terms of improving care for the elderly?
There is a lot to be learned, I think. And, something was mentioned now to pull together the system. I think it's very important, because in a crisis or in case of national emergencies, you need to fill out the gaps and see that the system as a whole works well together to support the individual person. There's, of course, things to be learned and also things to deal with after the pandemic. And one thing that was mentioned was isolation that can result in mental ill health because of isolations. So we have to consider how we can offer better both support and treatment for elderly persons with mental ill health. And we will also carry, I would say, some kind of a debt to family members that have been burdened during the pandemic because of lack of support and unwillingness to move, for example, their elderly relatives to nursing homes or to receive elderly care. So therefore, you can expect somewhat of fatigue among family members that are supporting the fragile elderly. That is a debt that will come in, we will carry on after the pandemic. But we have learned that there is also a lot of opportunities, I would say. And one thing that we are working hard on with Sweden is a transition in the healthcare system to a hospitalized system, moving into what we call close care of high quality. That is care that you receive in your home based on increased resources to our primary care sector, and to receive care close to where you are staying, living, with help of self-monitor digital solutions and self-reporting systems. That is important, I think, just to prevent people from building up more ill health and to detect needs of health care and health treatment in an early stage of the disease. So that is a transition in Sweden that we will carry on after the pandemic, and we have got great support and push that transition during the pandemic.
Absolutely. Ms. Newman, you brought up a very interesting point about how healthcare in the U.S. is very siloed. I mean, I'm a political reporter. I've covered the responses in New York and Florida to very, very different approaches with, a high elderly population in both states, but two very, very different outcomes. Going forward, how, do you really see the system becoming more unified between all the states going forward, or do you think that's a long-term goal, really?
Well, I'm trying to stay optimistic today, but Yeah, I think we do have a federalist country, right? We have 50 states in DC and territories, and the whole idea is there's a fair amount of autonomy that states have within certain constraints. So there's a bit more that the federal government can do through, say, the Medicare program, which is a national program, and it has standards and it can make changes, but many decisions were left up to states. And so to the extent that states are responsible for certain aspects of our healthcare system, that's not going to change. The states are also responsible for rules pertaining to masks, for example, and I don't know that that's going to change. I do think there could be creative work done on silos in a different sense, which is having Medicare and Medicaid communicate better with the public health systems. And I'm wondering whether or not that would be possible. I mean, I was actually a little bit surprised that it took a while for Medicare to know when people in Medicare facilities had COVID or died from COVID. That I would think that would be an opportunity for real-time information to feed a response. So I think in the end we are a country of many states, so we're not going to be changing that, but there are opportunities to do some things in a more unified way.
Right. Well, I'd like to thank you both for joining this panel today. It's a very important discussion, and I'm happy to see more elderly people in both Sweden and the United States getting vaccinated. So hope is on the horizon. Thank you so much. And now I'd like to move on to our next panel, which is a topic that's very interesting to me, and I know to many other viewers in Sweden and the United States, and that's telehealth. And you might have heard it referred to as telemedicine or e-health. I'm very happy to introduce two experts on this, emerging trend that we're seeing in this kind of healthcare. We've seen that the COVID-19 pandemic has very much served as a catalyst for this healthcare, and we're very excited to see how this pans out after the pandemic. The speakers for our last panel are Dr. Marcus Lingman, Development Strategist at Region Holland Hospital, and Dr. Klaus Torp Jensen, Chief Digital Officer and Head of Technology at Memorial Sloan Kettering Cancer Center. Thank you to you both. Dr. Torp Jensen, how about we go to you now?
So telemedicine is a fascinating topic because we tend to think of it as a virtual interaction. We're on video here having a conversation. That's not actually difficult. That's something that's known. It's a known technology. It existed for a long time before the pandemic. We've had video conferences. So what's different when you start talking about telemedicine, you have to think about what do people need to actually be ready for? What do providers need to be ready for? And what happens from a regulatory perspective? Telemedicine as a concept is the idea that you can have a journey of care, a journey of health that isn't just about the visit. It's not just about having a conversation with a provider. It's basically about taking care of your needs in the same way that you would have if you were going to a facility. So what changed for the people that are on the patient's side is they're no longer going to a facility. There was a fear of going out. What they want is something that's local and easy. On the provider side, we could have set up a video conference, and in fact we did. That was the first order that many organizations did with respect to telemedicine. But the real question was, how do you change your clinical workflows so that all the stuff that has to happen before the visit, you have to do the scheduling, you have to make sure that tests get done the way that needs to get done when that's appropriate. You have to make sure, in our case, that you have a multidisciplinary team that's ready to have a conversation. It's not just about the oncologist, the specialist in cancer. It's about nutrition. It's about physical exercise. It might be about a clinical trial. So it's a multidisciplinary team. And on the patient side, how do you pull in friends and family? When people are in this kind of stress situation, it's important to have support around them. There were regulatory concerns. Before the pandemic, you couldn't actually get reimbursed for a telemedicine engagement in a reasonable fashion that would cover the cost on the provider side. There were all kinds of regulations around state level licensing. So if you are in one state, that's where you're licensed, and the patient is in another state, even if it's a neighboring state, you're actually not allowed to do anything that has to do with care. So all these things were accelerated. People's acceptance of telemedicine as a first-class engagement model happened pretty much immediately. Within weeks, the providers had to shift to doing audio video, and then we had a couple of months to figure out how to actually change the clinical workflows around it. Within the first 2 months, the authorities changed what they allowed as well. So where are we now? I don't think that gene is going back in the bottle. People have gotten an appetite for doing things virtually where appropriate, not as an alternative to regular care, but as an integral part of a hybrid care. Our strategic assumption is we will have 35 to 40% of our visits, and we've got about 800,000 a year. We'll continue to be using virtual channels, but now as part of the regular care model, not as something that sits on the side as a, some people's mind, not as good alternatives. It's going to be no different than the fact that you have choice between inpatient and outpatient. Now you will have a choice about virtual as well as a component of your care journey. Most of the providers have figured out how to do the visit. Most of the providers have figured out what it means for clinical workflow, but doing it in a way that's scalable and durable at a permanent level without creating stress and burnout on staff that's trying to use suboptimal tools is the next generation of telemedicine tools and platforms. And from a regulatory perspective, it remains to be seen what's going to happen. I do think that the reimbursement ability is probably going to stay in some form. Exactly what it looks like, we don't know. Right? Nobody knows what's going to happen. We're out of the pandemic crisis situation. The state licensing, that's a state decision. As was just discussed on the prior panel, I mean, we are a country of 50 states, and each state has their own rules. And it's down to the individual state legislatory bodies to decide what their rules are for licensing. And it gets complicated because even if you're on vacation or you are in your summer home, current state, most of these local regulations are about where the patient is, not where the provider is. So a lot to do, I think, on the regulatory side before telemedicine becomes a permanent part of the American healthcare model. I've no doubt we will get there, and I do think that the people that need care and the providers are more than ready to take the next step.
Thank you so much, Dr. Jensen. And I think we now have Dr. Lingman, who can now give his remarks.
Thank you, Julia, and thank you, Swecare and the Swedish government for arranging this forum. Over the past years, we have gradually established the concept of information-driven healthcare, working along the value chain of knowledge, systematically refining granular data into information and further into insights, informing behavioral change and guiding new investments that lead to better outcome for patients. The work covers the entire care chain across all silos of the healthcare organization and includes data from all relevant components of care to assess both resource utilization and care quality. In this work, it became obvious that we need to move value creation to less resource-intensive venues. Here, telehealth and patient empowerment play key roles. But equally important is the increased precision in the provision of care, a precision more and more often leveraged by the predictive power of applied artificial intelligence. Telehealth is already a mandatory part of integrated care, but there are still challenges with respect to the need for the seamlessness in the comprehensive healthcare ecosystem. COVID-19 has put healthcare under enormous load, but it has also served as a pressure test of the maturity of the organization to embrace new solutions. The pandemic has exposed the craving for non-physical and asynchronic healthcare encounters to a degree that is difficult to keep up with. Widely spread solutions like video consults leapfrogged into the comfort zones of both providers and patients, and behavior will be permanently altered in cases where going back is harder than going on. Newer tools like teledermoscopy and continuous holistic monitoring of the health of individuals using a wide repertoire of sensors are entering the real-world scene, and more futuristic telehealth applications like remote robotic surgery are closing in on reality. The radiologist no longer needs to be in the same town as the CT scan. The parents of children with type 1 diabetes can monitor the blood sugar in school with instant support of the pediatrician when needed. All these sensors add to the wealth of data already in place in healthcare, providing innumerable opportunities for research and innovation in the direction of tailored, patient-centered precision healthcare. The ongoing shift from inpatient to outpatient care has also been accelerated, but to reach farther, we need to go beyond traditional ways of care provision into the hybrid world that includes virtual care in the patient's normal living space. The merger between medicine and technology has gone so far that they are now inseparable, and medtech is a crucial part of the life science industry. What we have seen thus far is not even the end of the beginning. In a short while, we will dig deeper into specific challenges of the development and share insights on how to tackle them. In doing this, and inspired by other successful enterprises, we need to stay focused on the product. And the product in healthcare are health, longevity, and sense of security among the people who might need our collected services. This should guide us going forward, developing new and embracing existing solutions with a clear return on investment in mind. Today, we have with us a number of great US and Swedish companies that are all committed to improving the lives of others. What they all have in common is that they are crucial links in the value chain of knowledge, either gathering data, transporting data, turning data into information, creating insights from it, or affecting behavior, or all of the above. I think many of us have learned that this is not an IT department task, nor is it purely a clinical task. Rather, it's a work that calls for true collaboration between specialists from computer science, medicine, telecom, law, policymakers, payers, and providers. I will stop here and finish by quoting Dr. Eric Topol from the Institute, saying that digital medicine is becoming just plain medicine. Thank you.
Thank you so much, Dr. Lingman. Now I'd like to ask you both a few questions, and I'll pose this first one to the both of you. In terms of telehealth and telemedicine, what parts of that field was really accelerated during the pandemic? Dr. Jensen, I'll go to you first.
I think I'll sort of begin where Dr. Lingman left off and say it's not actually about just technology. So what's accelerated, I think, is the fusion of physical, digital, and clinical. If you think about it, historically, we've looked at these spaces as being distinct. Right? There's a physical world, I go to the doctor. There's a clinical thing that happens in the doctor's office. Or I can go to my digital tools, and that's a patient portal, and it's all about paying the bills and administration, etc. That barrier disappeared. It was always going to disappear, but it kind of disappeared overnight because you no longer had any choice. So we're now looking at a world where we have fused physical, clinical, and digital. And we've renewed another barrier, because if you look at American healthcare, there's a distinction between individual care and treatment and population health, which is about how you stay healthy. Look at the system we have. There are different players that are addressing different parts. That barrier disappeared too. Because when you break the barrier between physical and digital, all of a sudden you have the ability to actually meet people's needs in a more holistic fashion. And it's not just about the treatment and care. It's as much about taking care of anxiety, of fear, of giving people knowledge and guidance, and basically delivering to the needs of the whole human, and not just the part that has to do with disease and treatment.
And Dr. Lingman, I'd like to ask you the same question. What has accelerated in this field during the pandemic?
Well, certainly the sense of urgency has accelerated, realizing that physical encounters is going forward only one part of the healthcare provision and healthcare system. And what has been accelerated is also the utilization of the data generated in order to be able to work fact-based across silos. During this pandemic, we realized that collaboration was the key to success. And for true collaboration, you need to share ideas, but you also need to share facts and information. And what happened was that this development was not driven top down, but rather bottom up, where point of care staff initiated new projects and reached out for new solutions, some driven by patients. And we heard from the cancer care team earlier that patients chose not to show up, not to reach out for care, and that's pretty serious. So we needed to set up new lines, new ways of communicating and offering care, and that was happening spontaneously, bottom up, I would say.
Absolutely. And I'll go to you both again, looking ahead, let's say to the next 10 to 20 years from now. What do you think telehealth and other digital solutions in healthcare will look like? I'll go to you first, Dr. Jensen.
10 to 20 years, that's a long time out. I'll start with the first 3, and then I'll talk about the 10 to 20. I think there are 3 imperatives that we have to get really, really good at in the next 3 years, and they run on different timelines. The first one is this idea of hybrid care, giving people the right care components in the right place, in the right way, using the right mechanisms in the right channel, whatever you want to call it. And it goes across inpatient, which is going to the hospital and you're being admitted, outpatient, which we're increasingly doing. If you look at cancer care today, certainly the way we do it, the vast majority of what we do is outpatient. We're now pushing the boundary on that even further and saying, how much can we do in the hospital? And with the ability to give real-time monitoring, you might even do home infusions. Certainly the injectables are possible to do at home. We increasingly have the ability to take care of people for long duration treatment paradigms and monitoring at home, not necessarily in the facility. That changes people's lives in a fundamental fashion. I don't think we have more than 6 to 9 months to get good at that because it's expected. And we can't continue to run in an inefficient system in that hybrid care model we're talking about. In a 12 to 18 month frame, we have to figure out how to show up local and easy. It's all about accessibility, and local is no longer just a physical thing. How do you show up the right way with the right emotion attached to it so this feels like it's for me? The third one is about shifting left in the care continuum, helping people earlier before disease, giving them knowledge, guidance. How do you navigate the system? What does it mean if I have a genetic risk factor in my family? I know that there is a family history of breast cancer. What does that mean for me? And what are my options and how should I think about it? So 3 years, those 3 things we have to get really good at. If we look at the 10 to 20 year time frame, now we're into research. Dr. Lingman talked about data. We have more holistic data sources. We may be able to finally crack the code on some of the disease biology that isn't just related to what happens inside a cell or inside an organ, but related to what happens in the environment around you. If we have engagement models that last longer, we'll get more data, we'll have more powerful analytical tools, and maybe, just maybe, we'll get to the point where digital models will help us weed out the bad ideas in healthcare research so we can shorten the cycle, which today is about 15 years from problem defined until discovery and new standard of care. I'd like to get to 5. So 20 years from now, maybe it's only 5 years between needing to solve a problem and having a solution.
Right. And Dr. Lingman, I guess looking forward to you, how do you think telehealth is going to transform in the next decade or so?
Well, I think it will be merged into the existing ecosystem in a more seamless way than today. We're increasing the siloification, the fragmentation right now in healthcare, and I think that needs to turn. That tide needs to turn in going forward to reach a more holistic healthcare. And Dr. Torp Jensen talked about fusion and hybrid care, and that is, I think, really that's the way we're going forward, internalizing telehealth into the usual care that we see today.
Absolutely. Well, thank you so much to you both for your valuable insights on this. I'm definitely looking forward to seeing how telehealth really transforms itself in the future. Thank you again. And now I'd like to move on to the in-depth part of our day-to-day, those breakout sessions. Now, these breakout sessions will consist of the 3 topics we've gone over: cancer care, elder care, and telehealth. Don't forget to manually turn on your microphones and cameras so everyone can see you. In these breakout rooms, you'll be able to network and get more in-depth knowledge from the experts as well as company representatives. Thank you so much for joining us for this panel. It was wonderful getting these experts' valuable insights on these 3 important issues amid the coronavirus pandemic. I hope you all have very interesting discussions in the breakout sessions to follow. Thank you.